Good evening and welcome to Let Kids Be Kids Round 2. My name is Jacqueline and I'm one of the founding members of Families for Choice. We're thrilled to be co-hosting this event tonight. We are Canadian families united in our mission to end COVID-19 restrictions for children. In October of 2021, a small group of moms got together to brainstorm ideas of how we could make change. We wanted Canada to start putting children first. From that meeting, Families for Choice was born, and we haven't stopped since, growing to approximately 25,000 members. For 2 years, Canada has been in and out of lockdowns. We've had various restrictions put on us, mask mandates and vaccine mandates imposed, all in the name of safety, but without taking into consideration what this is doing for our children. It's time for this to stop. Kids can't wait. They need to get back to normal, and not a new normal, but pre-pandemic normal. Now, I'm just a mom, and my assessments, my feelings are based on my real world experience and what I know my children need. But tonight's event is so exciting for the founding members of Families for Choice because we have 4 incredible doctors on this panel who will be teaching us from their perspectives as highly educated and trained physicians using real world data to explain to us why our assessments as moms is actually correct. On our panel, we have Dr. Martha Fulford, who is an associate professor at McMaster's University. She is the chief of medicine at the McMaster University Center of Hamilton Health Sciences. Dr. Fulford is also an infectious disease specialist for adult and pediatric patients. We also are joined tonight by Dr. Khrista Boylan, who is a pediatric psychiatrist and associate professor in the Department of Psychiatry and Behavioral Science at Neurosciences at McMaster's University. She is also a faculty member at the Oxford Center for Child Studies. We are also joined by Dr. Richard Tytus, who is an associate clinical professor in the Department of Family Medicine at McMaster's University. And last but not least, we're joined by Dr. Dennis DiValentino, who I've had the pleasure of getting to know more over the past 2 weeks. He has been instrumental in making this event come to fruition. He is passionate for advocating for our children and getting them back to normal. And we are so grateful for all the work he has put in to make tonight happen. Dr. DiValentino is a family doctor in Hamilton, Ontario, and he is also an associate professor at McMaster University. So without further ado, I'm going to turn us over to Dr. Tytus. Thank you all for being here with us tonight, and we're so excited to hear what you have to say.
Yeah, thank you very much, Jacqueline. This is a great opportunity for us to share the science. And the science has changed over the last 2 years. And the question is it time to pivot? So we're dealing with let kids be kids. We're talking about our children, our grandchildren. Is it time to change, or is it time to update what we're going to be doing for the future? This segment is we're going to have a presentation by Dr. Fulford. Then afterwards, we've segmented in 4 distinct areas. And we're going to initially talk about COVID, the background, schools. We're going to be, next section will be about masks. The 3rd section is going to be mandate. Do we need mandates moving forward? And the 4th section is the future. What is the future and what does the future hold for us? So after each section, we'll have an opportunity to do a panel discussion. We invite you to submit questions and we'll review your questions. And so we want to make this as interactive as possible. So without further ado, Dr. Fulford, please.
Thank you very much, and thanks for inviting me to do this. Some of it will be a little bit similar to a talk I gave a few weeks ago, and some of it's a little bit different. So forgive me for anybody who may have seen the previous one if there's a bit of repetition. But again, we're talking about sort of some of the more specific impact on some of the restrictions to our children. I'm going to mention again, I have no conflicts of interest to declare. I have no funding for any of this work I'm doing. And because of the current climate, I would also like to say I have no political affiliations. I'm just doing this because I'd like to advocate for our children. So I'm going to do, as we said, we're going to do sort of the 4 sections that Dr. Tytus mentioned. So we'll start with where we're at right now. And a little bit of perspective, a lot of what I'm going to talk about is not just COVID, but put it in context to other risks that we're used to, that we understand and accept. This is the pandemic curve as of a few days ago in Canada. You can see unquestionably, it was January 28th, that we had a pretty high number of cases happen. And it's important to take that in context, as is true of everything. So if you look at the graphs underneath, the patients that got admitted to hospital, looks like we've had a big jump, but a lot of those were incidental. I think more important is if you look at the little curves and the people in ICU or the people who are vented, that we have a major disconnect now between how many cases are in the community and what we're seeing in terms of critically ill patients. And in fact, if you look at, for example, ICU and critically and mechanically vented, we're actually lower than we were 2 little waves ago, if you look at the bumps. So this is exactly what we wanted, was what we call a complete decoupling of cases from severity. It's Omicron that's mostly circulating, the sort of the purple-gray, and that's on that picture. And these numbers are, this information is all available from Public Health Agency of Canada website. And again, for the context, if you look at what COVID has done, this is the top 15 causes of death. This is from British Columbia. They put this out from the beginning of the pandemic to end of October of 2021. COVID was the 8th cause of death. So it wasn't number 1, it was number 8. And it caused fewer deaths than drug overdoses, which is the yellow sign. And also I think it's important to note that if you look at the COVID deaths, the average age of death from COVID is 82. And if you look at drug overdoses, the average age of death is 44. And this is more for context. It's not to try to minimize the impact of COVID. It's in no way to try to say that we haven't gone through a very difficult 2 years. But I do think that 2 years in, we need to think about exactly what the risk is we're facing. And then this from the British Columbia breaks down again the severity by age. And you can see it's really not a significant cause of death until we hit sort of the 40 and even more so 60 age group. And so in no way to minimize the impact of COVID or to denigrate anything that's happened in the last 2 years, but context is important as we move forward and as we try to pivot to moving out of pandemic mindset. This is on the one is the US numbers where we can see pediatric mortality and COVID as a cause of death compared to other common causes. And on the right, I actually did that myself. I looked at all the numbers from StatsCan from 2014 to 2019. I averaged out the 10 most common causes of death in 0 to 19, and then I put in the COVID deaths. And it's for perspective. So in the 0 to 19 age group, while COVID can be a problem for some children, we need the context. It is nowhere near as severe as a lot of risks that we accept on any given day. And so again, in no way to minimize the tragedy that may have happened with somebody who has COVID, but to remember that there is context here, and we deal with a lot of other similar risk factors all the time. And this is actually from a fellow called John Byrne Murdoch, who does a lot of analysis for the Financial Times. This is UK data. But if you look at mid-2020, the red line is COVID and the blue line is influenza. 2020, you can see up to the age of 20, influenza and COVID had the same mortality impact, but clearly was significantly more lethal as we went up the age groups. But look at what we're seeing this year, early 2022, January 2022. Red is COVID and blue is influenza. And really at this point, influenza is deadlier than COVID until you hit sort of that 50 age group where COVID becomes slightly more lethal. And so again, in no way to minimize COVID or to try to put down anybody who has experienced adverse events, but we need context, and influenza is something we're used to accepting. It can cause very severe disease, both of them, but we need to put COVID in the context of other respiratory viruses we deal with all the time. So what does COVID do? This is just to remind us that we have coronaviruses all the time. Every year there are 4 circulating coronaviruses. There's a very well understood seasonality to them. Usually it's sort of October to spring, but they circulate year round. And they're a very common cause of upper respiratory tract infections. So why am I mentioning other coronaviruses? Because COVID is a coronavirus. And so if you look at the clinical presentation, we look at what it does to compared to seasonal coronaviruses. They both now have about an average incubation period of about 3 days. They can be asymptomatic, but they can also cause severe pneumonia, both respiratory, our seasonal coronaviruses or COVID. And we always knew that coronaviruses could cause a bad viral pneumonia. It was the third most common cause after RSV or influenza. So this is adult. If we look at pediatrics, very similar. Average incubation period of 3 days, often asymptomatic, and by that, a child can have virus in their nose but be completely well. When they're symptomatic, it's pretty typical cold/flu type symptoms. Bit of a viral, maybe a runny nose, maybe a bit of a ear infection. It is a common, not an uncommon cause of hospitalization in some kids, but very uncommonly a cause of severe disease, and seasonal and COVID are actually very similar, actually. So we're not seeing a big difference at this point between COVID-19 in pediatrics and the 4 seasonal coronaviruses we deal with all the time. So this is, some kids are at higher risk though, and this has to be acknowledged. This is from Canadian data looking at what pre-existing health conditions might predispose a child to be more likely to be admitted to hospital. And you can see that severe neurological disease, obesity, and severe underlying lung disease are the most common. There's a few others, but by and large, if you look at the percent of hospitalizations, there's some fairly clearly identified risk factors. And this is from the Canadian data where we've looked at pediatric hospitalizations and tried to figure out which child is more at risk of being admitted to hospital. And then Omicron, just because that's what we're surrounded with, very, very transmissible, but even milder disease than our previous variants. And what we're seeing is even more typical cold type symptoms even than our previous variants, which were already mild in children. And we do have studies confirming this. It's not just sort of our on the ground impression. This is a study that looked at the numbers from California, and it was in children, and it did show that there was clearly less severe outcomes, and for the kids that did end up in hospital, almost half as, the duration of hospital stay was 50% shorter, so clearly milder. I used this before, but this is from January 4th from Global News, and to me it epitomizes a lot of some of the misunderstandings. This is a real headline. It said, cough, cold, or COVID-19. Doctors say with symptoms overlapping, it's impossible to tell. And honestly, if you can't tell which one you have, you just have a cold. It really doesn't matter what virus is causing it. I'm going to touch a little bit about long COVID, because this is also often raised as one of the specters about why we have to keep kids in restrictions. We do have studies, and it's important that we study it. It can't be medicine by anecdote or what somebody happens to post on social media. We really need good studies to show this. This is a review article that looked at 14 studies. Unfortunately, most of them are actually very poor studies. And it's very important to have what we call a control group in a study, so that you have kids with confirmed SARS, kids without, that have never had it with SARS-CoV-2 with COVID, and kids without it, so you can actually see whether there's a difference between the children who had the infection and they didn't. Of the 14 studies they looked at here, only 5 of them had control groups, and 2 of the 5 showed no difference. Only 3 out of 14 studies really had enough data to even see if children were more likely to have these post-infectious syndromes, or so-called long COVID. This is a UK study. It looked at quite a big number of individuals, just over 26,000. This was a properly matched control group. They followed them weekly. They had a clear definition of what long COVID would encompass. It was 12 of the most common symptoms. And it's important, if you look at the numbers in kids, that if you look at the kids that had COVID and then the control ones that didn't have COVID, there's really no significant difference. And in the 2 to 11 year age group, oddly enough, the control ones had more of these so-called long COVID symptoms. So it's important to distinguish what is a true post-infectious syndrome from a lot of the other pandemic restrictions, what that has done to the psyche and sort of the health and well-being of kids. So it's not to say that post-infectious syndromes don't happen, they do, but they're not very common. And there's actually one newer study that just got published from Denmark, and this is another it's probably the largest of all the studies. They identified 15 symptoms. They tracked these children very closely. And really, the the conclusion is that long COVID in children is rare and mainly of short duration. So again, very reassuring that this is not some reason to worry about our children and should they become exposed to COVID. I'll go through this really quickly because the big fear about the schools is that somehow they're hotbeds of transmission. We have many, many studies that have consistently shown that schools are not amplifiers of infection. They reflect what's happening in the community. I think I just skipped one. No. So this is one from British Columbia. They looked at the blood sort of serology of teachers to see whether there was any higher risk in teachers than anybody else in the community, and there was no difference. So teachers working in the classroom, even when the kids were not masked, showed no higher risk of getting COVID. This is another similar study from Vancouver, that school-based transmissions were uncommon and the clusters were small. I've provided a list of references, or where I've got all the different studies from all these different countries that people can look at that have consistently shown that transmission in schools has never been shown to be a significant issue, and schools mirror community activity. Not to say that there's never transmission in schools. As I say, they've mirrored what goes on in the community. And it's also important to remember when we think about this, that almost all the school transmission studies were done before vaccines were available, so that the concern that the children might be transmitting to teachers or vulnerable adults is really essentially gone away, because any adult who chooses to can be vaccinated, and that does protect the adults. So even should there be a little bit of transmission, that fear should have been taken away from anybody who's in the schools. And then the flip side, of course, is that not being in school is not without consequence. And we know that we've seen significant impact on our kids. And it's what some of us are referring to as a parallel pandemic of harm. And as a society, and I've been saying this for a while, we need to decide what's a priority. And as far as I'm concerned, the health and well-being of our children is a priority, and our policies are whatever's best for our kids. And it's a separate policy than what might be best for adults or best for a hospital or best for a nursing home. Our children deserve their own policies and their own priorities. Again, I can go through these really quickly, but we've seen just so much collateral damage. Decreased physical activity, obesity, the loss of structure, loss of personal relationships, isolation, mental health issues, drug overdoses. And you saw the drug misuse issue. If you look at the British Columbia deaths, that there are significantly higher deaths from overdoses in the younger age groups than from COVID by a lot. Increase in suicidal ideation, lots of increased exposure to violence and addiction in households. And a lot of this is hidden because some of the things that flag a child that's being abused or that might be exposed to violence is in fact interaction with neutral adults. So it's the teachers, it's the coaches, it's the people who might be teaching them dance or the extracurricular activities. And so depriving a child of all of that contact can actually further expose them to more violence. And then I'm not even sure we're going to be able to document for a long time the harms from an interrupted education and all the lost opportunities that come from that. And to me, this is actually probably going to be one of the most profound generational catastrophic things that we've done. So this is a UK study on decreased language acquisition and speech comprehension. We talked about opioid deaths. This is actually an interesting one from the British Medical Journal that showed that children born during the pandemic compared to children born pre-pandemic actually are scoring lower on cognitive tests. And this isn't because they've had COVID, it's because we've narrowed their lives and their interactions, their exposure to other children and to other adults. And it's actually, we're starting to see this in terms of lower cognitive scores. Obesity, as I mentioned, lots of eating disorders, and this is well described across Canada that we've had explosions in terms of admissions for eating disorders. The mental health crisis is well documented, both in terms of admissions, in terms of calls to helplines, in terms of the wait lists to our mental health professionals, and we don't have very many or anywhere near as many mental health professionals that can deal with children, so that's an issue. And then, of course, this was October of last year where they finally, they declared a national emergency in children's mental health, but this had been building for a while, of course. Children First Canada, again, documenting the threats to our children because of the pandemic. So this is not secret. This is very well documented. And yet here we are still having conversations about what to do best for our children. And I think obviously most of us are trying to advocate for a return to normalcy, and these are all the reasons for that. So this is going to be our first pause, and maybe deal with questions about COVID and the context or perspective of COVID before I move into masks and specifically.
Yeah, perfect for that information. And I might add that Dr. Fulford is a co-author at a COVID think tank from the U.S. It's called Urgency of Normal.
Yeah.
So you might want to refer to that. That's urgencyofnormal.com.
Yeah, easy to find. Urgency of Normal, all one word, urgencyofnormal.com. It's a toolkit on, returning to normal. Yeah.
So we're hearing about the potentially negative or untoward effects of this COVID pandemic restrictions on our children. And I've got this really good question I think really kind of highlights that particular aspect. It's healthy kids are at a statistical zero risk of severe illness. And I have to highlight healthy children without any comorbidities. And that's really important to highlight. And vaccination does not prevent transmission. Sweden has decided against vaccinating their young kids because the risks outweigh the benefits. So the question is, why is Health Canada pushing vaccines on our healthy kids while saying they are following the science?
So that's a great question, which maybe I'll defer till part 3 when I talk about vaccines.
The vaccine part.
So after masks, I'm going to talk about the vaccines. And so maybe I'll try to touch on that then.
Okay.
I'm not trying to weasel out of it. I will address it.
But it's just food for thought.
Yeah.
And so before we continue, I'd like to get the perspective is we have Dr. Boylan with us. She's a pediatric psychiatrist, and pediatric psychiatrists are very rare. So it's a great opportunity for have insight of a pediatric psychiatrist. And my question to you, Dr. Boylan, is what is the impact of these COVID restrictions on these sort of the collateral damage that you're seeing in your pediatric practice?
As a child psychiatrist, I am generally seeing kids that are quite ill. And we have definitely seen an increase of referrals of kids that are quite ill, right? So that means that the impacts, and this is relating to the timing of COVID/COVID restrictions. And it's not due to COVID as a virus. It's due to the changes in children's lives on so many levels, right? The restrictions have affected family life, school life, access to peers, changes in daily routines, social communication. I mean, there's so many things. It's just actually overwhelming to think about all the impacts that come together due to restrictions on mental health. So in my daily life, I'm busier. I'm definitely triaging and worrying a lot more about young people who are very compromised. Dr. Fulford is absolutely correct that unfortunately, particularly older teens who are trying to start their lives and transition out of high school, and then also the really younger ones. So we're seeing more of an impact on the older teens as well as the younger ones, where we used to really see most of our patients sort of being 14, 15. And the issue is around hopelessness and suicide risk management, or unfortunately treatment of suicide attempts. So those are things that have absolutely changed over the past 2 years. And then the other challenge that comes with that is that these restrictions not only affect children, but they affect adults, they affect community-based treatment programs that have had to shut their doors or reduce their spots for kids. So not only do we have more need to treat, we have less resources available to offer families. So it's kind of strangulating for children's mental health in the tertiary care setting for sure.
Dr. DiValentino, as a family doctor, have you seen the impact on your patients?
Yeah, I think we're seeing exactly what Khrista is seeing. Of course, Khrista will see the more severe stuff, and in the family practice world, things will pile up with some of the less severe cases. But what we are definitely seeing that I'm not used to and very concerned by is the age at which children are starting to have these mental health discussions. Using terms like anxiety, using terms like depression, actually describing what Khrista had mentioned. They're describing hopelessness. And we know that hope is probably the number one thing when it comes to health of all populations, but particularly kids, their whole lives in front of them. And we're having these much more intensive, from a mental health perspective, discussions at a much, much, much younger age. And then the double whammy that Khrista pointed out is there are less resources available to deal with these issues. And then the last thing I would layer in is actually starting to see drug misuse and abuse at ages I'm just simply not familiar with seeing it. And so I think really this is a clear message that we need to pivot and get these kids back on track, because treating this is going to be very, very difficult if we don't.
Yep, thank you. Yeah, I had a discussion with my son, who's a family doctor. He had an 8-year-old come to him and ask him about anxiety. She said she had anxiety, she had difficult sleeping, and she used those terms. Now just think back, when you were 8 years old, did you know what anxiety was?
No. No.
So at this point, let's move on to the next section. And the next section we'll be talking about the importance or the non-importance of masks.
Yeah. I called this section, What About Masks? As is true of much of the COVID conversation, it's very polarized. And so it goes a little bit into this whole issue of safety and our schools safe and our kids safe. And I always sort of want to push back, safe from what? I mean, what are we trying to achieve when we say schools are safe? And as we're discussing, what's causing most harm to our children? And I would, I think most of us feel that the harm is not having our kids in school. We can talk about ventilation, we can talk about all of things that may or may not help, but really it comes down to, what's best for our kids, and is there any reason to close a school or to not have a normal school because these measures aren't there? And I would say absolutely not. And I'm going to talk specifically about masks, but I'm also then going to talk both about the studies and then sort of what's happening internationally, because I think it's helpful to look overseas as well. So do kids need masks? Interestingly, 2 years into this, we have no good studies that actually show this. And we also know that most jurisdictions have actually never masked children under the age of 12. So we actually have a lot of international studies showing that kids can have no masks on, can be in school, and the sky does not fall in. But it's very difficult because it's become so polarized. And the minute you try to have a conversation about it or have nuance, accusations and terms go flying around about being pro-mask or anti-mask. And it's just very difficult when you're trying to sort of have a middle ground conversation. And this conversation I'm having is specifically about the role of masks in schools on children, on our students. And I do think that it should not be polarizing to say, can we talk about it and can we look at what the evidence shows? And it is, of course, the most visible and probably the most controversial in a lot of ways part about the ongoing school mitigations because it covers our faces. And so when we have this conversation, it helps us be in the context of what COVID does to our kids. And I think that the risk perception is completely out of sync to any reality. It's very clear that children are at very, very low risk from COVID itself, and even lower with Omicron. And then for adults that might be around our children, if any high-risk adult can be vaccinated, and the vaccines do reduce the risk of severe disease, so the situation and the conversation should be okay to have without it being really challenging. So when we think about the studies, we should look at real world use, and they need that matched control group. It's the same as we're talking about things like long COVID. You have to have a comparison of a school that has masks, a school that doesn't have masks, and just look at that one intervention to know whether or not masking our kids makes any difference at all. And there are studies that look at this, and interestingly, they don't show that masks make much difference. This is a study from Georgia, and it's, of course, long pre-vaccine. It's interesting because they actually did show that there was, at the time, a reduction when teachers wore masks with ventilation. But what this study did not show was that students wearing masks made any difference at all. There are some confounders in this, and some people are picking it apart, but really there is no statistically significant difference between the students wearing masks and not wearing masks in terms of COVID transmission because of the confounders. So this is probably, as close to a pro-mask study as you're going to get, and it's pretty bad. This is actually the United Kingdom reviewed all of their data on face coverings in educational studies, and this is from January of this year, so this is very up to date. And they actually showed that there may have been a small reduction in transmission, but it was inconclusive. But the small transmission, if they looked at it, was actually a drop in schools where there was no masks. The drop was of attendance was 5.3 to 3.6%, so a little bit of a drop. And in schools with masks, it went from 5.3 to 3%. So really only a 0.6% difference between the two. Then, when they looked at all this thing, they said it was a net 11% reduction in COVID cases with mask usage. But they actually couldn't even be sure if this benefit was real, because if you look at the actual numbers of what we're looking at, they're pretty small. And they basically said they couldn't really show that masks made any difference. And then here's a whole lot of other studies. This is one from Florida, looked at data from Florida, New York, and Massachusetts, and there was no correlation with mask mandates. So basically there was no change whether they were wearing masks or no masks with transmission. Study from Wisconsin, no significant association between COVID-19 incidence and mask use. And finally, this is from Spain. And this was an interesting one because they were not masking 4 to 5-year-olds, but they were masking 6 to 7-year-olds. So they could compare the two cohorts, and there was absolutely no difference between kids, the kids that were masked and the kids that were not masked. So again, no evidence that the kids wearing masks made any difference at all. And then some of the studies that have been cited as evidence that masks do work have no control group. And this is really problematic because if you're citing a study that say that masks work, but every school in the district that you're looking at had students masked, you really can't say that that intervention made any difference to transmission. And then one of the other studies from Arizona is problematic because they didn't control for vaccination rates. And this is a huge confounder because if you don't actually split the two, the decreased transmission, the decreased sort of severity of illness may in fact have been entirely because of vaccination. And there's a couple of really thorough critiques on this. And the conclusion was you can't learn anything about the effects of school mask mandates from this study. So basically it was of no use. And then the last one, which is also often cited as supporting mask use, had the same confounder about vaccinations. But the other interesting thing is that the schools that were most likely to have high vaccination rates, ironically, were the ones that had the strictest mask requirements. You'd think it would be the other way around. But instead, high vaccination rates were actually correlated with a lot of mask use because I think they're the most risk-averse communities. So again, we have exactly the same problem, is that there's absolutely no evidence that the masks themselves had anything to do with decreased transmission. And so basically, we're 2 years into this, and we actually have no scientifically established benefit that masking our students makes any difference at all. And if there is a difference, it's very small. And so when you have an intervention that has no demonstrated real-world benefit, or it's so small that we can't really measure it, then we should actually be very comfortable stopping it. Because if it's not doing anything, then we need to revisit it. We should be allowed to say, this isn't really working. Maybe it did at the beginning, maybe it didn't, I don't know. But as we've tried to systematically study it, it's pretty clear that if they have an impact, it's exceedingly low. People say, well, what's the harm? I mean, we are starting to see harm. I mean, they're poorly understood. We certainly have studies that have shown and anecdotes that when kids don't have to wear masks, that there's a huge improvement in mood. We're certainly seeing studies in terms of speech acquisition and children, particularly with disabilities, being impacted. And then this is, I'm going to actually, sorry, not yet. So the potential harms are poorly understood, but I don't think they're insignificant. So if you have no benefit and possible harms, it's something you should stop doing. Also, we have a lot of international experience. And this is where I ended up using photographs because I had trouble trying to tease out every country and every jurisdiction to try to put in writing what they were doing. This is a photograph that actually I've used a few times. It's the first day of school, September of 2021. I put Ontario, but it could be anywhere in Canada. So we have Denmark, first day of school, with the kids just going into school. All their belongings are there. There's no masks. There's no restriction on their activities. And you can see what we're doing here with the kids masked. They're lined up. Their hands are behind their back because they're not allowed to touch anything. And then these are examples from around the world. Anybody can Google this or whatever search engine you like. And what I did was I just searched stuff like kids having lunch at school 2021 or sports at school 2021 to try to sort of get just images of kids doing stuff in other jurisdictions. And you can see that it's not hard to find a lot of places where kids are pretty normal. We have a sports team up there in Chicago just this month. This is a program in Virginia in 2021. We have Florida. This is a Georgia school band. We have sports teams. We have Jamaica Day in 2021. That was actually August, but still, it was last year with it completely unmasked. Norway kindergarten class, the UK. There's a lunchroom in Virginia this month in the middle there. So that's those are the kids all sitting together, having their lunch together. We have a team playing volleyball in January in Ohio. You notice in the back there's 2 kids masked. So a little bit mask optional. Some people are still uncomfortable, and that's okay. We need to respect personal choices, but most are not. Again, a band. We have Red Nose Day in the UK with the kids in their costumes. We have a cheerleader team in California and another school band. Normal lives. And then this is Ontario. This is in October of 2021. It's a school in Scarborough. This is our kids here. This is actually a photograph that Dr. DiValentino sent me. These are kids in Toronto entering school, one by one, with, interestingly, what appears to be confirmation of their screening on their backpacks. And of course, they are all masked. Some of these are actually not from Canada, to be fair, but they reflect what's happening when severe restrictions are in place. So some of them are from the US. But that picture on the top is one that actually makes me want to cry. Those are 2 little girls who are best friends who are running to hug each other because they hadn't seen each other in months. And what the 2 teachers are doing are dashing over to split them up so that they have to keep their 2 meters apart. We can see what's happening in the desks in the one room. There's a lunch break you can see in their little squares all by themselves sitting on the cement. These are kids lined up going into primary school. And again, you can see that the children are being told they can't touch anything. Their hands are have to be kept close to their bodies. Their faces are unseen. That's a kindergarten allowed to play in their little boxes. Actually, one of my neighbors, her 8-year-old was telling me that all she's allowed to do is play in her zone during recess. And one day she spoke to her friend in the other zone, and the teachers put a barrier up so that they couldn't speak to each other in their 2 zones. I mean, what are we doing? You can see the lunchroom there with the kids really isolated. Now, I try to be apolitical, but I actually decided to put these in after all because I think that they just speak volumes to the hypocrisy of what's happening. So on the one, we have New York City Council. We have some celebrity celebration of some sort. We have a sports team. And then we have kids at school. And the other one is, again, hypocrisy. It's on the bottom, it's our world leaders in November of 2021 in Glasgow, all having some meal with the waiter masked in the back, and our kids having lunch, also November of 2021. Those adults, fully vaccinated, are if assuming they're are at much higher risk of landing in hospital, even fully vaccinated, than any child sitting by himself or herself is. And so again, we have to sort of have the perspective of why are we doing this to our children? These are the countries that mask young kids. These are the countries that do not mask kids, and these are some of the places where it's intermittent rules. I mean, it's hard for me. I actually try to look it up country by country, so it varies a little bit. But what's very clear is that the standard has not been to mask children in schools, and particularly not to mask young children. And so it's very uncommon for the 12 and under. That's actually, we're in a minority of countries by doing this. This is actually an anecdote sent by a colleague of mine. It was, she got sent this by one of her patients. It's a mother sending her this to one of my physician colleagues. They need to see expressions and find joy in school. They need to see when their friend is happy or sad and react to that. They need to see when their teacher is annoyed or happy. It's like she's apathetic. There's no compassion. How do you develop or sustain that when you can't see the cues? She doesn't seem to have much joy. She's trying. It has been very hard to watch. He hates masks, but his school sports give him a lot of joy. There's no masks there. We have to remember that these kids who are becoming apathetic and lack emotion may someday be called in to take care of us and our community. They will need to heal before they can do that. I don't know why teachers are so scared. They are all vaccinated. This seems to sum up what I think most of parents are seeing in their children. And it's hard to study that, but how do you study that draining of the joy of life by just not letting people see faces and see smiles and just read emotion? And that is what masks do take away from us. So that's pause number 2.
Yeah, so we've had a flurry of questions, and one of the comments was, why is the science of wearing masks different in Canada from the rest of the world? Is that a rhetorical question?
So masks became, I actually don't know. I mean, masks became very political very quickly. It's a symbol. They become a symbol of sort of trying to prevent or trying to do your bit to stop the pandemic. There have been 2 studies that have been done to look at community masking with COVID. One was in Denmark. It was called the DanMask study. They had 6,000 people, 3,000 with masks, 3,000 without. It showed no difference, actually. The big criticism at the time of the DanMask study was that the study wasn't looking at whether the mask stopped a person from transmitting it. So it made no difference a person getting COVID, but then it wasn't powered to look at whether it stopped somebody from maybe giving it to somebody else. And this was this whole, I wear my mask to protect me or to protect you business. The other much bigger study was actually from Bangladesh, which looked at surgical masks versus cloth masks. They found that cloth masks made no difference at all. Surgical masks reduced transmission by about 11%, but this was only seen in people age 50 and over. The mask made no difference at all in terms of COVID acquisition in younger people under the age of 50. So the 2 studies that we've actually done on mask wearing in communities have actually not shown that they work. So why we're not letting go of this is hard. Now, of course, if you look around the world, there are some places that are not masking at all, countries where it's optional, where they allow people to make a risk assessment. I don't understand, actually, the politics or the emotional attachment or the inability to have a conversation, somehow meet in the middle. I wish I understood it. I've been trying to advocate for a while now that, polarization is not good and that there's probably a middle ground. A lot of occasions where masks are probably not necessary, and on our children in schools, it's pretty clear from the evidence that they're not necessary. On the other hand, crowded transit, a big subway where you've got poor air circulation, lots of people close together, you can't really maintain your distance. Maybe there's a role there. But even there, we should be studying it instead of just assuming it. But I think that there could be a lot of personal risk assessment as well in terms of the mask wearing, and we just haven't really allowed that conversation. Has become sort of an all or nothing, and nuance. I mean, the nuance has just disappeared from the conversation.
Yeah, some of the comments are, these photos are bringing tears to my eyes and making my stomach upset. This is inhumane, cruel, and abusive. My 5-year-old does not want to get up and go to school any longer. My 6-year-old wants to see someone smile. They're missing the smile. And that's kind of interesting because there's also a group that, Martha, that you're associated with, and it's Bring Back the Smile.
Yeah.
.ca.
Yeah, so we're working on this. It hasn't gone live yet, but there's going to be a website called bringbacksmiles.ca. So it's just a beta version right now, so it's not up, but we're working on it. Hopefully this weekend it'll go live. And it's also what the urgencyofnormal.com initiative is about. It's exactly that. We need our kids to be normal. And the fact that kids are normal and that their schools are normal and that they're taking part in extracurriculars and that they're allowed to be kids again, this should be striking to us that half the world kids are being kids, and in Canada we have these unbelievably harsh restrictions on our children, and it's not rational and it doesn't make sense to me, which is why I'm sitting here obviously advocating for return to normalcy and trying to bring these messages out, looking at the data, looking at the evidence, looking at the international experience. This isn't about politics, it's not about personal beliefs, it's about what have we learned in 2 years, what do we know about COVID and the risk to our kids, and what can we learn from international jurisdictions? Because if every school in Scandinavia can be open and no child has ever had mandatory masking in those schools and all extracurriculars are open, if they can do it, we can do it.
So science is dynamic and it's changing, so possibly maybe it's time to pivot.
I would think so.
So our next section, our next segment, we're going to be discussing vaccine mandates.
Yep. So the vaccines. So as I always like to start with any conversation, I like to sort of give us a little bit of context because vaccines aren't all exactly the same. So the perfect vaccine is one that stops all clinical disease, prevents all transmission. You end up with herd immunity and the disease is eradicated. And we have actually done that once, and that's with smallpox. Most vaccines are in this sort of group B, where they prevent most clinical disease. So most of the actual physical signs of the illness are averted, and most onward transmission is stopped, but not all. And then we have some vaccines where, at a minimum, they prevent severe disease and death, but they don't actually stop transmission. They don't lead to herd immunity and to eradication. Obviously, in a perfect world, all vaccines would be A and all disease would be gone, but of course that's not at all what we're seeing. And so the COVID vaccines fit this category C, which is that they're very good at preventing severe disease, but they're not really stopping transmission. This doesn't mean that they're failures of vaccine. It means that we acknowledge that this is what they can do, and we target how we use them to prevent severe disease. So when I say that they're not stopping onward transmission, I'm not trying to say that they're a failure. I'm saying that we need to acknowledge this is what they do, but we also have to acknowledge what they don't do. And we have seen a clear decoupling of cases from hospitalizations. I think the graph I showed at the beginning where you see how high the curve has gone in Canada, and you look at the fact that our hospitalization, our severe disease is really down, is testament to the fact that the vaccines do stop severe disease in people who are vulnerable. But obviously the benefit of the vaccine is going to vary depending on the age, because COVID has a very severe age gradient in who it affects. It is essentially spares young people, very uncomfortable person to have a bad outcome, whereas the older we get, the more vulnerable we are. And so that benefit, the decrease in transmission, is a powerful tool, and we need to acknowledge it's a powerful tool. So when we think of and actually this is data from Denmark, and you can see that if you look at the graph from the age groups from 12 to 15, they don't vaccinate under 12, so we're only starting from age 12. That really, whether a person is unvaccinated, has 2 doses, had a booster in that age group, really doesn't make a lot of difference. And as you sort of go up, you'll realize that the orange line, we start to see more hospitalizations as people get older, and it really becomes quite significant in the sort of 50 and definitely the 60 plus group. Vaccines, whether it be 2 doses or the booster, are pretty similar in terms of protection until about age 70, and that's 65 to 69, 70. You start to see that the 2 doses that people do benefit from a booster at that age. And this is pretty compelling. So there's clearly a role for the vaccines, particularly if you start to look at who's most likely to be hospitalized in the first place. This is from British Columbia, actually. It's a little bit backwards, but the gray are people with no vaccine. Then pink is 1 dose, purple is 2 doses, and then the 3 doses, which is just our older people in BC. Now remember, the 0 to 4 aren't being vaccinated at all, so you can't really compare that. So you can see that, yes, as people get vaccinated, there's a slightly lower chance of being hospitalized, but that this is most obvious in above age groups. So while lots of people can test positive, that the hospitalization rate is decreased with the vaccines. And then sort of, if you look at the 0 to about 17 age groups, there's maybe a little bit of a difference from being vaccinated. And that decrease in hospitalization rates is going to be most obvious, of course, in the children who are at high risk in the first place. And so again, this isn't all healthy children, but it includes all the kids with vulnerabilities. This is also from British Columbia, and it's actually a pretty nice table because it tells you by gender, so female, male, 0 doses, 1 dose, 2 doses, or 3 doses, what your risk of being hospitalized is, depending if you've got 0 conditions, 1 to 2, or 3. Really, if you're a healthy person with no risk conditions, your risk of being hospitalized remains exceedingly low. On the other hand, if you go to the bottom where it's 3+ conditions, where you see lots of orange, even vaccinated, there's still pretty high risk of landing in hospital. And so we can't get rid of all vulnerabilities and all sort of risk factors for somebody to end up in hospital, because we have people in our population who are frail, who have a lot of other medical conditions, who are just highly vulnerable. We can try to decrease that with a vaccination. But this is an important calculation, that risk-benefit conversation about who is most likely to benefit from a vaccine, and it's important to acknowledge that. There are uncertainties about the vaccines. We do see waning immunity at the 4 to 6 months, and that's why we could see the impact, the benefit of a booster in the 70+ age group. We know that even with just the 2 doses, we're seeing still clear protection against severe disease. Will we also see this in children? We don't really know. We haven't been vaccinating long enough. We certainly know in teenagers that the same waning immunity is seen. Kids have a different immune system. It's very robust. On the other hand, we've given them a slightly lower dose, 10 micrograms instead of 30. So I think some of these are just questions we don't know the answers to yet, because we haven't been vaccinating them long enough. And we continue to gather data on safety and adverse events, which are real. They're not common, but they're real. And acknowledging that some people have an adverse event to a vaccine isn't in any way minimizing the benefit of the vaccine. It's just being honest that part of the informed consent and part of the conversation is these are the benefits and these are the potential risks. We don't know whether children will benefit from a booster because we just don't have that data. They may never need a booster because they have a good immune system. We may see waning immunity. What the ideal time for a booster would be, I don't know. My personal opinion, which probably may not be worth a lot, but I would see this being like we do the influenza vaccine, where we see what variant is circulating. We develop a variant-specific vaccine, and that's offered October, November, just before we see our huge sort of seasonal wave, and it's offered to those who are most vulnerable to severe disease. And so that could easily be an annual shot, as is the influenza shot for anybody who chooses to take it. But again, this is evolving knowledge. It may be that people will have such a robust immune response after Omicron that they won't need a booster. Again, we're learning. Is there a risk for increased adverse events with boosters? We don't know. We're learning. And again, this is in no way to say that there's anything bad about the vaccines. It's simply saying that this is a powerful tool that we're still learning about, that we're going to be able to target, that we maybe hone how we're using it. Some concerns in some jurisdictions, mostly Europe, where there's some, there appears to be maybe diminishing returns with each booster. And it may be because we're dealing with different variants. So the vaccine that we've got right now is the vaccine that was developed to the ancestral strain of COVID, sort of the original strain of COVID. And of course, we're 2 years in, we have Omicron. So maybe that it's a vaccine variant mismatch we're seeing. but they're also wondering whether giving too many boosters too soon, too quickly, may actually paradoxically end up with a weakened response to them. And so the timing and learning the timing of boosters is really important because each vaccine will have slightly different recommendations. So should children be vaccinated? Well, I think high-risk kids should be, yes. Children with neuromuscular disorders, children who are home vented. Obesity may be something to think about because it does increase the risk, albeit the risk still is very low, but we're going from very low to even lower. The recommendations from NACI, from our National Advisory Committee, says that it could be considered for any child that lives in a home with a high-risk adult or somebody who might not mount a good response to the vaccine. The vaccines don't do a great job stopping transmission, but they may reduce it a little bit initially. So again, it's something that I think could be studied a lot more robustly, but it could be a consideration. And this is in line with the policies in most countries. So that going back to that question that somebody asked about the vaccines, is that for example, the JCVI, the Joint Commission for Vaccination and Immunization of the United Kingdom, Norway, Sweden, a lot of countries have said that that because the risk of COVID is so low for children, they don't really see a lot of benefit in mass vaccination, but they are recommending it for high-risk children, and it's available for any parent who would like to have their child vaccinated. And it's a bit of a more open-ended recommendation, but which is actually very similar to what our National Advisory Committee on Immunization says, that it's essential that children and their caregivers continue to be supported and respected in their decisions regarding COVID-19 vaccination. So while we have approved it and NACI says it should be offered, they're actually saying very clearly that whatever decision a family makes, it should be supported and respected. So to be fair to NACI, they're sort of similar into what other countries have said. They're a little bit more in that it should be given, but they're not certainly saying it's mandatory or anything, which of course brings us to mandates. So when we think about the vaccines, I'm splitting it into the primary benefit to the individual and then the community benefit. The primary benefit is the reduction of severe disease to the person who's been vaccinated. Once a person's been vaccinated, that protection's there. We will all be exposed to COVID. It doesn't matter if it's a person who's been vaccinated, it doesn't matter if it's a person who's not vaccinated, it doesn't matter if it's a person who's masked or not masked. The virus is the same thing. We will get exposed one way or the other, and the vaccine to the individual who's been vaccinated gives them that protection. So that is there. And that's a very powerful thing, particularly for vulnerable adults. But the community benefits, or the public health benefits, are twofold. One is reduction in the surge to our hospitals, and the second is reduced transmission. The overall reduced pressure in hospitals is achieved by vaccinating vulnerable adults. You don't have to vaccinate a 20-year-old healthy person because that person will never be in hospital in the first place. So that part of our population isn't adding to the burden to our hospitals. So targeting vaccination to the people who are most likely to land in hospital gives them that personal benefit, but that's where we see the decreased pressures to our hospitals. And we know who's vulnerable. I mean, these are clearly identified risk factors now. It's advanced age, obesity, and the metabolic disorders. Poorly controlled diabetes, poorly controlled hypertension, this sort of package of what we call metabolic disorders. And this objective is there. We've met that objective. We have extremely high vaccination rates in seniors and in most vulnerable adults. But we have to remember that even with the best vaccination program in the world, we will still see people admitted to hospital because we have people who are frail, who are vulnerable, who have a lot of risk factors, who may not mount an immune response. And this is just a reality of respiratory viruses. They're not going to go away. We're not going to eliminate it. And it's not trying to be cruel or dismissive to say some people will succumb to a virus and will end up in hospital. But fortunately, that risk is dramatically reduced with the vaccines. But then we come to the issue of secondary transmission, and that's where the vaccines have not been shown to do a very good job. And I mean, I didn't put all the studies in here, but there are a lot of studies that have shown this now. But all you have to do is look at the rates in Canada, look at our curve. We have almost a 90% vaccination rate, and we still saw that sort of explosion of Omicron cases. And this is true of every country in the world, even with the highest of the vaccination rates. You can look at Israel, you can look at Portugal, you can look at Ireland. Everywhere, it didn't really matter. Is when Omicron hit, the cases went up. And so if there's no impact on secondary transmission, I personally do not see any justification whatsoever for mandates, because mandates are, I may not agree with a person's individual decision, but you have to have a really compelling reason to put a mandate in place. And I think we would have to have a really compelling public health reason in order to have a mandate in place. And if they don't stop transmission, it makes no sense. If a person who's been vaccinated or unvaccinated can equally transmit the virus, then the mandate doesn't, to my mind, make logical sense. And I'm of the opinion that coercion is not an acceptable reason. Coercion is a line that none of us should ever cross. I mean, I'm a physician. It is a fundamental of medicine that we do not coerce our patients. And then the final thing, which goes back a little bit to the question, I think, about the vaccines, is unfortunately we're in a little bit of a wild west of mandates, because even when our National Advisory Committee of Immunization says we should respect an individual family's choice, we have different jurisdictions, we have different organizations inventing their policies, we have sports team inventing, suddenly demanding mandates, we have school boards, we have dance classes, we have judo clubs. I actually have a problem with this. I don't actually think that individual organizations should just be allowed to make up their own rules, particularly when there's no public health benefit, and particularly when, for example, for children, there's really no mandate in place, or there shouldn't be. And so this is one of the areas where I think we could start to ask questions. I don't think we should be confrontational. I think that there's a middle ground here. You know, one can be very in favor of vaccines. They do a remarkable job at preventing severe disease in those who are at risk. But we just need to think about or ask, what is the public health rationale for a mandate? And for our children, I really see very little rationale. So for our kids, I do not believe that we should be putting barriers in place, we should be excluding them, that we should be stigmatizing them because of this decision. So it's personal opinion, and I realize that may not be in line with a lot of my colleagues, but I do think that we need to start to have this conversation.
Thank you. So before we move on to vaccines, I'd like to circle back about masks. And I'd really like to get Khrista's opinion as a pediatric psychiatrist, the impact of masks on our children, on our young children and older children. Like, I've had some of my patients, they're like 4, 5, 6. They're not comfortable being in public without masks. Just wondering, what are the psychological implications of that?
Well, that is a very good question. I don't know that we know that necessarily. One thing I would say that I could comment on is the fact that when children are really little, they are generally very compliant and they do kind of what they're told. And the impact of having to wear a mask all of the time for a little person who's really has not a lot of history of never having the option or not really recalling a time in their life when they didn't wear masks is questionable. And I think there probably are many children who are more vulnerable who would see that even trying to stop wearing the mask would be wrong, right? And it's unfortunate that has to become something that's particularly more anxious children will have to, I hope, deal with at some point in the future if we are able to have more freedom to choose when we're using masks with children. What I would also say, though, I mean, Dr. Fulford spoke to this nicely, and I'm definitely not an expert in early development, but the language and social experience, I mean, it's a fundamental aspect of what makes us human. And it, for me, as a psychiatrist, the key issue here is that it conveys emotion and emotional experiences, which we're depriving kids of in the settings where they're engaging with other kids, mainly at school, because of the mask. And that is common sense. And I think it is, without a good justification for doing it anymore, it's kind of ridiculous. And if I could just put a quick piece into the issue of vulnerable youth here, because we think about vulnerable people with respect to COVID because they're medically at risk of having serious complications of COVID. But there are vulnerable children from the perspective of mental health. I mean, all children have experienced some harms, but most are extremely resilient and will adapt and come back to a new normal, hopefully an old normal. But there will always be a vulnerable section of our youth who are vulnerable to mental health struggles. They're sensitive to environmental stresses. They're sensitive to a teacher yelling at them for putting their mask back on. Some kids will be like, you know what? But most little vulnerable teens will may be harmed by that. And the piece that I want to say, if I have no other opportunity tonight, is just that youth who are emotionally vulnerable will be harmed, and probably have been harmed, by the actioning of restrictions. So the need to comply, or the need to be mandated to do something by people who are well-meaning, like their teachers or their family members, who impose the restrictions on them when they're just forgetting to wear their mask, or they're hugging a friend, or being foolish around them without their mask on. Those are normal things, and to be told to stop doing that stuff in the service of being masked is a mental health vulnerability, as opposed to just the mask itself. So I hope that made sense. But that's the real mental health vulnerability going forward if we don't relax our paranoia about masks.
Yeah, no, Khrista, that's very alarming.
Right.
We seem to have, certainly from a psychiatric or psychological, there's many negatives of wearing a mask. And what we heard from Dr. Fulford, from science, there doesn't seem to be, there's minimal or any benefit of wearing a mask. So I think that speaks volumes. I was wondering what's your experience, Dr. DiValentino, with wearing masks, and what's your personal experience?
Well, I think we've probably heard from two much more qualified people than myself on masks, but I did promise my son Lucas, who's in grade 1, who's having a stay up late night tonight and watching, so hi Lucas. He has specifically asked me to ask the government if he can stop wearing his mask. I promised I would do that, so government, can Lucas stop wearing his mask, please?
Okay, and what about the things we took for granted? In the past, we could have birthday parties, we could have play days without wearing masks. Is it, and my granddaughter, she's going to be 4 in April, I guess February the 6th, and she's never had a birthday party. Is it safe for her to have a birthday party? Can she bring friends over?
I think yes.
Yes.
These are the milestones that we've taken away from our children. I sort of glossed over this, but friends and relationships, and birthday parties, school dances, graduations. These are important. Sports, winning a sports team, medal ceremonies. These are important milestones for children and youth, well, for adults as well. And really, again, it's that sense of perspective. Exactly what is the harm in having a birthday party? And particularly today, we're not looking back, but we're looking at where we are today. We have a virus that is a very low risk for children. We have a highly vaccinated adult population. We need our kids to be healthy. That is our future. And really, there is there's just no risk to letting a child have a party. Kids should be allowed to hug each other. They should be allowed to be friends. They should be allowed, when they get older, to have relationships. They should be allowed to go out and do stuff. This is not abnormal. And this is where this other group, this urgency of normal, is coming from. Now, the focus is on schools, but it's acknowledging that going back to normal is not an unreasonable thing for people to be asking to be able to do at this point in time. So I personally think she should have a birthday party.
Well, I'm going to let her know, so thank you.
And you were really just asking for you. You keep bringing this up.
Yeah.
Okay.
So yeah, and the reason I'm bringing this up is because there's a lot of angst. Like my daughter is suffering from a lot of angst. So some of the common things we take for granted before, like she's not allowed to go to the school, she's not allowed to go to the classroom, she doesn't know who Avery's friends are. So some of the things we've taken for granted before, they're not allowed to be done today. So the question is if you take a look at all of the world where they don't have the restrictions, children are allowed to interact with the other children, whereas now they're in their zones. Now I imagine there must be a psychological implication for this.
Yeah, that I think parallels what I was trying to say articulately, but failed to do, which is the infrastructure and the rules that are required to maintain zones are stressful for kids. And then, as I mentioned, children who don't want to break rules will struggle to adapt to a loosening of these restrictions. So we're going to have to go through a period of adapting. There has been adaptation that's already been done. And then we also have to think about how to help our teachers. We have to help our parents kind of figure out how they're going to loosen up in a way that's safe for them. But we also have to have people that monitor our children throughout the day and direct them as to how to behave and to cohort or not to cohort. We really need to help our teachers feel like they're doing the right things by being caregivers for kids and loosening restrictions. I have no idea how that will happen, but I'm hoping that people will at least be more open to it now, because I think this is the time to be talking about this.
Okay, thank you. Well, let's circle back to the vaccines, vaccine mandates, vaccine passports. Now, Dr. DiValentino, what about vaccine passports for kids? Is there a role for that? Or do we need that? Or should we do away with that? And I'm thinking of the context of kids that want to play sports, kids that want to go to dance recitals, swimming, etc.
Yeah, and I think Dr. Fulford was very good at explaining that the data is simply not there to suggest that there's a benefit to mandate. Okay, and if there's no benefit to mandate, i.e. no benefit in terms of transmission, then there's no role for mandate. If there's no role for mandate, there's no role for a passport, particularly in our children. And so the question comes to the extracurricular activities, where we start to look at some of the concerns we had, which is differences in the way that kids are treated based on vaccination status and just generally in terms of COVID management, particularly vaccination status. And so, no, I think I'm going to echo very strongly Dr. Fulford's sentiments, which is that we need to remove these type of restrictions from all areas of our children's lives, school and particularly extracurriculars. And I think as a family doctor, I can speak to the fact that this has taken up a disproportionate amount of our time at a very difficult time from a medical perspective. Number of discussions with parents who correctly recognize the value of extracurricular activities and just don't know what to do when faced with what seem to be coercive mandates. So I think it's causing a bigger problem than we're recognizing, and I think we need to very strongly speak against it for many reasons, but the main one, it's just not good for vaccines.
So you're really proposing vaccine choice?
It's about choice and what are the unintended consequences of vaccine mandates and lack of choice. Yeah. We've talked about this at length. I'm of the opinion that removing choice is something that's very disempowering, and I do not think on a long-term basis will lead to to the optimal uptake when it comes to vaccines, because it's not just this vaccine. We have a full vaccine program that's very robust and has been in place for decades. We don't want to do anything to compromise that. And so I'll just close by sharing the article that Dr. Fulford shared with me, which is a fantastic article. It's called "The Unintended Consequences of COVID-19 Vaccine Policy: Why Mandates, Passports, and Segregated Lockdowns May Cause More Harm Than Good." This is a very robust group of authors from Harvard, Johns Hopkins, U of T, Oxford. It's an international publication, and it goes very deep into the potential harms of removing choice and not making education and choice the center of the vaccine program. It's how it was built. It's how it'll be maintained. And I think there's some serious data that's coming up to suggest this may be the wrong approach.
I can add that reference to the list I gave you guys. I don't think I put it on, but it's a fairly recent, from like a few days ago.
Yeah.
It's a really good, it's a long read, but it's really good. It actually highlights exactly why, a person can be very strongly in favor of vaccines, like I am. I mean, after all, I'm an infectious disease physician, but against mandates, and these are not mutually exclusive positions. So when I say I believe strongly in vaccines, I do, but it's a tool that we can target, we can hone how we use it, and we can have specific recommendations for specific populations, and this is in line with how we use other vaccines. The other unintended consequence, actually, of mandates is it's leading to a lot of distrust, and we're starting to see a decrease in the uptake of other vaccines, and we're starting to see, for example, measles outbreaks in different parts of the world. And so when we think of inadvertent consequences, this is at a public health level, there's some significant inadvertent consequences in terms of the general distrust of the system. So when you take away choice and it becomes coercive, there's a withdrawal from a lot of other similar things. And so that's not really what we're talking about today, but for some of us, this is actually one of the big concerns we have, is part of the unintended consequences at the public health level as we move forward. But that's a different topic.
But we did a lot of work over many years to address vaccine hesitancy with education.
Yeah, no.
We just don't want to see a step back.
Yeah.
Right?
Yeah, and I think it's important to put it in context that we're all pro-vaccine for a vulnerable population. I know Dr. Fulford was out at the shelters and was a vaccinator. I've been vaccinating people in the retirement home, nursing home. I've been giving the third booster, and actually we're going to be giving the fourth booster in 2 weeks. But really what we're focusing on, let's kids be kids. It should be about the choice, and we're following NACI guidelines. And also it's important that the kids aren't ostracized if they don't get vaccinated. They shouldn't be excluded from any activity. And I think that sort of falls in what Dr. Boylan was saying, that it's undue stress on children. We don't want our children to be stressed because of this, because of policy.
Agree.
Can we do the last segment?
Please.
So this is, where are we going from here? So this is, again, the context, which was that we're in a very different position now than we were 2 years ago. And we've learned a lot about COVID. And one is, of course, we've talked about the vaccines. The vaccines have done a remarkably good job at reducing the overall risk of severe disease. Again, it's not zero, and that would have been an unrealistic expectation, but we've seen a really significant decoupling from case counts and severity. But also, we have a much better idea of how to manage COVID when somebody gets it. In hospital, we have much better ways of providing oxygen, of how we ventilate, and so the in-hospital mortality is much lower than it was at the beginning, because we've learned a lot about management. And we have a lot of treatment options now available when people do get COVID. There are outpatient treatments. There's ways we can monitor low-risk patients, strategies we can put in place. We know exactly what sort of the danger signs are that somebody might progress to more severe disease. We have a lot of early treatments, both for people in the community, for people in hospital. They can be scaled up from just like an inhaled steroid, something called budesonide. There's oral antibiotics, there's fluvoxamine, there's monoclonal antibodies, there's other specific antivirals. And I'm not going to go over this at all because it becomes very medical, But certainly in Ontario, for example, we have very clear guidelines that categorize patients into tiers in terms of risk factors. We have strategies exactly how we can, what we would put for lower risk, moderate risk, or high risk person, and as well for people who are in hospital moderately or critically ill. So that the whole scenario is very different in terms of what we're dealing with COVID. And so it changes, again, the conversation. It should change the focus because it's just not the same as it was 2 years ago. And this is where we talk about how do we move forward. And this is sort of, people probably heard this conversation of pandemic versus endemic. And pandemic, this is just a diagram from the BBC I found, but a pandemic is when you have a sudden increase in a disease all across the world, and that's obviously what happened with COVID at the beginning. When we talk about an epidemic, it's when you have an outbreak in a particular area but not around the world. An endemic was something that's constantly present in a population at sort of either a low spread or predictable spread. So it could be a seasonality that is the same, as we see the seasons go. And when does it become endemic? Usually when there's enough baseline population immunity that a large number of people don't get sick at the same time. So when we have a new virus, so H1N1 in 2009, COVID, it hits the population, we have no underlying immunity, you get a lot of people get sick at the same time, you have this huge surge of people and you have this huge surge into the hospitals. But at 2 years in, for example, with COVID now, we have significant population immunity. It's a combination of vaccine and acquired immunity because we haven't really talked about this, but people who get COVID and recover do mount a very good response. We have a lot of good data on this now, very good studies that show it's very robust. CDC report from a couple of weeks ago actually showed that people that had previous infection and recovered were actually less likely to get Delta than people who had been vaccinated. So in other words, acquired immunity was a bit better. But we don't want vulnerable people to get COVID, obviously. We would prefer them not to get COVID and be vaccinated so they don't end up in hospital. But for the people who've had COVID and recovered, they have immunity. So that's really how we get population immunity. But the other end of a pandemic is a little bit of acceptance it's a psychological thing as well. Because strictly speaking, if you look at what we're dealing with right now with COVID, in terms of just severity of disease, we're not really in a pandemic anymore in terms of numbers. So if you look at how many people are admitted to hospital right now in January, and you compare it to how many people are admitted to hospital in January for the last 10 years, or actually I guess for February now, but in a winter season, we don't actually have more people admitted to hospital, and in some ways there may be in some places there may be fewer. So in other words, what we're seeing in our hospitals in terms of volume is similar to what we would have seen in previous years. We are very challenged in terms of staffing, and that's a different conversation. But this is sort of having this conversation of pandemic versus endemic. And then when I say when I say about severity of disease, this is again the UK data, which is really robust. If you look at how many kids have been admitted because of COVID since the beginning of the pandemic, it's just over 15,000. But it's still quite a bit less than the mean annual admissions for what we would call viral wheeze, for a condition called bronchiolitis, for ear infections, middle ear infections, otitis media. And that graph, it's the same Financial Times data crunching that it's a very good site, this Financial Times data. But if you look at the red line, that's the number of COVID admissions we've just had. The blue line is RSV, standard one. But those gray things, that's what we would normally see in an annual year. So if anything, our numbers are lower right now. So again, in terms of severity of disease, what we're seeing is very similar to what we might have dealt with on any respiratory tract, sort of a respiratory virus season. And I think anybody's following the news, the pandemic is now over in a lot of countries. Every time I look, there's one more country that got added to this list, but these are countries that have essentially removed all restrictions. They said it's over, or they're about to. Like I think, was it Switzerland or Sweden? It's going to be March 1st, but most of these countries have moved on. They're saying we're no longer in a pandemic. And this is not to say that COVID's gone away. Nobody is saying that COVID's finished. What they're saying is that this is an equilibrium that we can live with now, and that there is no further role for restrictions, and many of these countries are dropping passports as well. So these are essentially places where it is now no longer pandemic. And so these are just my thoughts. Like I said, I think clinically what we're seeing now is that COVID is just another coronavirus. And in no way to minimize what's happened to us in the last 2 years, but we are in a very different situation, both in terms of population immunity, in terms of treatments available, and we still have to acknowledge that we have hospital capacity issues. When we think of our kids, the health and well-being of our kids is separate, and I do not believe that we should be linking what we do with our kids with hospital capacity. These are two different societal problems. We need to sort out hospital capacity, but not at the expense of our children. And so kids going to school and kids being allowed to be kids and kids going back to normal is one conversation, and it's not the same conversation that we should be having about hospitals. So it is time to pivot. Do we need masks? I think it's a reasonable question to ask. What is the role of a mask in a fully vaccinated population? What is the rationale for doing this? I do think that we have a very, very powerful tool in the vaccines, and now we need to further refine and target and hone how we use this incredibly powerful tool, because it's not uncommon to have recommendations that are population-specific or season-specific. It's in no way taking away the value of a vaccine to say we can now target how we use it. I think it's incredibly important that we do look at other jurisdictions to see what's happening and what's worked and not worked. I would like very much if we could have civilized debate and discussion, sort of meet in the middle ground. I think polarization is terrible, it's dangerous, it's divisive, and there's misinformation on both sides. We need to sort of get rid of the misinformation and try to have common grounds, because we do need to start to work on repair and recovery. I also feel that we need to acknowledge as a society there's been a lot of collateral damage. Businesses have been destroyed, dreams have been shattered, children have been harmed. We've removed a lot of people's social supports, whether that be a church or a synagogue or a mosque. We've taken away their sports teams, we've taken away choirs, we've taken away sports teams. So getting people have these back is part of returning to normal. It's validating that, yes, people have been hurt, and it's not because of COVID, it's because of the measures. And it's not to say that they were all unnecessary, but neither should we minimize that. And one final thought is we absolutely 100% need to stop blaming people. It's not children who are responsible for this virus. It is not people who are vaccinated responsible. It's not people who are unvaccinated responsible. It's a virus. It's a respiratory virus, and viruses do what viruses do. It is nobody's fault if there's transmission. Because this blaming of people, this needs to stop. I'm going to end with this slide, which is an op-ed that was in the British Medical Journal in December, and it's called "The End of the Pandemic Will Not Be Televised." And what it says is that as an extraordinary period in which social life was upturned, the COVID-19 pandemic will be over when we turn off our screens and decide that other issues are again worthy of our attention. Unlike its beginning, the end of the pandemic will not be televised. And this is exactly what we're seeing in a great many parts of the world, that it's just finished and they've moved on. And I'm going to end with that.
Excellent. I just want to review some of the most popular. We've got 100 questions here, but some of the most popular ones are: I want freedom of choice for my kids and the right to continue their education without being segregated or denied education. Masks for me at this point is a metaphor to keep everyone silent. I think vaccine passports and all mandates need to disappear for everyone, period. We're hearing that it's time, maybe with the science, we're looking at the science, and based upon science, maybe it's time to pivot, time to change how we're reacting to this virus, in particular when it comes to kids. And my concern is, what happens? Is there a fallout? We talk about long COVID for adults, but what about the untoward effects? Maybe I'll turn to Khrista about that.
Dr. Fulford mentioned before that it will take a while for research to catch up for a couple of reasons. One, that research takes a while to do well. And when we're thinking about mental health outcomes, we can't get a snapshot immediately to help us understand the future. We really need to have repeated assessments of what's going on because humans adapt. They also have high stress responses, and transitions are very difficult for humans. I mean, this is just what we see. If this had been some other kind of catastrophe, we'd see similar types of problems with teenagers and kids and their mental health. So we don't absolutely know. What I would say is that if there's anything that I know in terms of what our capacity is to be helpful for those youth who are struggling or will have a struggle in the near future, is that we don't have the capacity to deal with the volumes of young people and families who are going to be coming and seeking help. We know for sure, hard data is that numbers are up at least 20 to 25%. And that was like last year. And so the impact of ongoing restrictions over time is emotionally more difficult. So I suspect that we'll continue to see more and more impact over the coming year, just in terms of help seeking. And as others have mentioned, there just really are not mental health professionals whose area of expertise is the under 18 age group. It's tiny compared to the adult mental health services sector. So that's where I'm particularly worried, because our wait lists for mental health treatment were long before the pandemic, like 18 months, and they're longer now. And that's our problem. So it's as a world, but if we're focusing on Canada, we need to be thinking creatively about how we're going to meet this healthcare need. And there's a lot of things happening, but if anything, that's our healthcare crisis right now, and it will be at least for 3 to 4 more years. And how do we resource that, and how do we make services available for the level of need? I have ideas, but it would take a couple of hours to go through them all. But we definitely need to step up to the plate to talk with our local authorities about how to rejig things. And it's a lot of work, and it's going to take away from patient care as well, because of the amount of infrastructure building that's going to require to meet the need.
Well, hopefully the policy makers are hearing this, and they'll give you a call. Is there any advice that you can give mums and dads how to help deal with the kids now that are suffering from anxiety?
Right. As anything relating to mental health and struggle, it's incredibly important to mirror to the child or teen, or to validate that their experiences are very real, and to try to help them anchor that to something. So the biggest challenge that particularly younger children struggling with mental health deal with is thinking that there's something wrong with them. And that shame and that internal focus is what generally happens for most young people. And most of our mental health efforts are helping families be with that youth, acknowledge the struggle, not blame, not try to fix it themselves, and recognizing also that there are many other people in that child's life that can also be helpful to them. Some families will struggle with meeting that need on their own because, as has been talked about, a lot of families are under tremendous stress due to the pandemic that has nothing to do with their child. And so I say the first step would be to recognize that there could be issues. If the child comes to you, to validate that you understand that they're struggling, and try to talk with them about what may be happening, so that the shame or the struggle that the child experiences is taken outside of them. And that actual approach, I think Dr. DiValentino and yourself, you do this a lot in family practice, is to try to normalize the struggle and externalize it so it's something that can be managed. And oftentimes that reduces a lot of the distress that families are dealing with. So I would say to start there, because not necessarily everything that kids are experiencing is mental illness.
So I guess in terms of it's time to have these play dates again and birthday parties, not on Zoom, but in person. And it's okay to see your grandparents if they've been vaccinated.
Yeah.
Dr. DiValentino, any thoughts, final thoughts?
Yep. So I just wanted to come back to one of the comments Khrista made, which is that, you know, we know that there is a mental health problem in our kids, and given the resources of the situation of the system, we think it's probably going to be bigger than our ability to properly care for it. And I think that's important, but also the important point was that research takes time to do. I'm guessing the outcome here is not going to be positive or even neutral. It's some degree of negative, and that's what we're going to go about measuring. But the very important thing about this particular research that Dr. Boylan referenced is that it's still ongoing and we can impact the outcome starting today. That's what's important. So we're going to measure it, but let's make it the least negative possible, and let's turn this thing around to put our kids on a positive track so we can get past this with the least possible impact on the least number of kids. And so I think that's important. We're going to do the research, but let's start to impact the outcomes.
Excellent. So each one of us can make a difference with our children, with our grandchildren, with our neighbors, and we need to start today.
That's right. And I just wanted to say a couple thank yous.
I was going to say, Dr. Fulford, if she had any last thoughts?
No, I think I've said what I needed to say. The one thing I do, would put a plea for is that we need to stop the polarization and just acknowledge that things have happened. This is where we are. I don't think there's any point in looking back and blaming anybody, but we are in a very different position, and it is time to move forward. It is time to pivot. And it is time to remember that health is more than just no COVID. I mean, health is physical, it's social, it's mental well-being. It's not just the absence of something. And we need to go back to that focus of health as being that global sense of well-being. And so for our children, it's not COVID that's the problem, it's everything else. And my plea is that we start to acknowledge this and let our kids go back to normal. And that means none of these mitigation measures that really aren't necessary at this point.
So, I'd like to thank the panel, but before, I'd like to also thank Banty and their staff here, and behind the scenes we have Craig on the camera, we've got Awad here on the soundboard, and we got Mark producing, so I'd like to thank the Banty team. And Banty is a virtual medical integrated platform. And so this allows doctors to hopefully see patients at home or wherever they are. And I'm hoping down the road is that for patients that can't access physicians easily because they live on the far reaches, they can use a platform such as this. And I'd like to turn it over to Dr. DiValentino.
I just wanted to say a big thank you to Families for Choice, the entire group, for having us on and asking us to speak again to this subject that we just feel so passionately about, letting our kids be kids. And specific thank you to Jacqueline, who's been absolutely wonderful to deal with over the last couple of weeks. And we reiterate this very important message that brought us together. It is a strong belief that our kids should be kids again, and that choice should be returned to the center of these medical discussions specifically. So thank you for the collaboration. It's been absolutely wonderful. And also, I just want to say again, thank you to Dr. Fulford for being a consistent voice on behalf of our children, saying that as a colleague and a parent. Thank you.
Keep trying.
Yeah, and I'd like to also add to thank Catherine Carruthers, and also we have to thank you. We have to thank all of you for attending today, because that's how we make a difference, okay? We need each of us to go out and sort of spread the facts. There's a lot of misinformation, and you're going to find all the references in this presentation. And afterwards, people have been asking, is this information going to be available? So Mark and his team is going to break it up in consumable YouTube videos. So it'll be like 15 to 20 minutes, and you'll be able to look at different aspects. If you're interested, you'll be able to share it with your friends. So wish everyone I guess a good night. Okay.
And
so,
all birthday parties should proceed.
Yeah, and so Avery can have her birthday party, and she can now see her grandparents, i.e. me and Rita.
My name's Catherine Carruthers. I'm co-founder and spokesperson at Families for Choice. Wow, my mind is absolutely blown. I think that is probably the most important and most compelling presentation that any of us have seen recently. And so there's some key takeaways from that for us and as parents. The first one for me is, listen, we're almost at the end of this thing. We're moving from pandemic to endemic. And so it's very important that we don't normalize what has been happening over the past 2 years. And so we all have to work together as parents, as doctors, as media, as politicians, as bureaucrats, as school boards and teachers to start to find a way to move on and move past this. Our kids are relying on this. One of the hardest things for me as a parent, I have 2 young children, is I felt despair at times whenever they've asked me, Mummy, when is this going to end? And for children, uncertainty is so difficult. And as a parent, it's so hard not to be able to offer the question or offer the answer to your child. And so this presentation has really given me much optimism that we are in the final sprint, hopefully, of this very long marathon. And hopefully, please, media, we know you're here. We know the politicians are on this session tonight. Thank you so much for joining us, and school boards. Please, we need this discourse. We need this information to be shared. Please, parents, talk about it. Tell your friends and share it. We owe it to our kids. So thank you very much for that. One other thing I'd like to mention is that, yes, the vaccine mandates have been having a huge impact. And we know that anecdotally from our own membership. One of our volunteers has been incredible at gathering anecdotal information from families. And so if anybody does have a story from their child as to how the mandates and restrictions have been impacting them, please feel free to share that with us. You can do that direct from our website, which is familiesforchoice.ca. One thing that we always love to do in our meetings is we give a shout out, and usually it's for an individual or a group. Tonight, it's for the parents. Parents, we see you. We see how hard this has been on all of you. And please be assured that we are working, our founding team, our volunteers, we are working from the minute we wake up until the minute we go to sleep to get normality and let your kids be kids. And we're so thankful for Dr. Fulford and team for doing the same thing. This is the time, we're recording this the first week of February in Canada. There's a lot going on. It's a very fluid situation and things seem to change by the hour, if not the day. So we just have to hang in there together. We need each other more than ever. We need to cherish those relationships, stick together. As Dr. Fulford says, this is not the time for polarization any further. We have to come together for the children, and we're doing everything that we can to influence policy. We're not politicians, but we're influencing policy via public opinion. It's the fastest way to influence policy. And that's why our plea tonight is to please help us get this information, spread it as far and wide as you can. In terms of where you can watch this afterwards, we'll be sharing the link to the video via our mailing list. So please go to familiesforchoice.ca, sign up for our newsletter, and you'll be able to access the video from there. So again, thank you so much to the panel. We've really enjoyed what you've had to say. And thank you very much to everyone for joining us tonight. Have a good night.